Welcome, everyone. My name is Yvette Gaughan. I am a Medical Affairs Associate Manager with Nestle Health Science. I have the pleasure of introducing today's speaker and assisting with the Q&A session. Before I introduce today's speaker, what do you think the following numbers have in common? 1.2, 86, 11. Well, I'll tell you. In a study by Weiss et al., hospitalized patients receiving greater than 1.2 grams per kilogram per day of protein showed lower mortality compared to hospitalized patients receiving less than 1.2 grams of protein per kilogram per day. And did you know hyperglycemia is present in up to 86% of critically ill patients? And last but not least, a very high hydrolyzed whey protein and low carbohydrate formula showed a significant decrease, 11%, in the number of times insulin was administered in critically ill overweight and obese patients compared to a high protein standard formula. To learn more about how these numbers affect patient outcomes, I am thrilled to introduce today's speaker, Dr. Todd Rice, who will address glucose management in the ICU, the evolving role of nutrition. Dr. Rice is an associate professor of medicine in the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University. He serves as the director of the medical ICU and takes care of critically ill patients as an intensivist at Vanderbilt University Medical Center. As a physician scientist, he conducts clinical research in the ICU, specifically in nutrition in critically ill patients and care of patients with sepsis, ARDS, and acute respiratory failure. Dr. Rice has over 100 publications, including journal articles, abstracts, and book chapters, and continues to design and conduct numerous studies in critically ill patients. Dr. Rice is also an author on the most recent ASPEN, Society of Critical Care Medicine collaboration for the Critical Care Nutrition Guidelines. And with that, I am thrilled to turn it over to Dr. Rice.
So for the next 40 minutes or so, I'm going to kind of walk through a number of topics, all surrounding glucose management in the ICU, and kind of try and paint a picture about some nutrition concepts and what we can do with nutrition in this role. And here's specifically what we're going to look at. We're going to look at the evidence demonstrating the optimal amount of calories and protein administered to critically ill patients, summarize evidence assessing blood glucose control in the ICU, and talk about harmful effects of both hypoglycemia and hyperglycemia. And then the last probably 15 minutes, we'll walk through some nutritional management modalities for controlling blood sugars in the intensive care unit in critically ill patients, and not just insulin. So traditionally, we have tried to feed patients in the ICU early, feed them enterally, feed them full calories, and in essence, use the same principles as we would in normal human beings. And that is, our composition has been largely carbohydrates with about, you can see there, 35% lipids and about 15% protein. And we've done this for decades. And recent literature has suggested that this hasn't necessarily been fruitful in improving the outcomes of our critically ill patients, and that maybe we need to be more thoughtful in how we provide food and what we provide in that food for our critically ill patients. Studies have found that goal nutrition may not result in the best outcomes, and that protein may be more important than non-protein calories. Maybe we need more protein and a higher percentage of protein in the formulas that we are feeding our critically ill patients. That levels of serum glucose affect patient outcomes, so maybe carbohydrates are something that we should pay more attention to as negatives in our critically ill patients. And that hyper and hypoglycemia both will worsen outcomes. So here's some early data. This is actually our data from the ARDS network and the Eden trial, showing that maybe full calories are not always beneficial to our patients. And this was a randomized trial of 1,000 patients randomized to trophic feeds, which was defined as 20 kilocalories per hour, or full feeds for the first 6 days of their critical illness. And you can see on the left separation of the arms between about 400 kilocalories a day in the trophic group versus about 12 to 1300 in the full feeding group, representing 25% to 75% as a comparison of the percent calories on the right. And we couldn't see any difference in the outcomes of the patients. Now, this is what we call a funnel plot. And if I can use, the pointer, these are actually survival curves. And these are actually curves coming off the ventilator, so being extubated off the ventilator. You can see that there isn't any difference in survival between the trophic and the full, and there isn't any difference in coming off the ventilator and being discharged home. The areas of this graph are informative, and they tell you what the status of the patients is. Everybody above these curves has passed away. Everybody between the curves is still alive, but still on the ventilator. And everybody below the curves is discharged from the hospital off the ventilator and alive. And no difference in any of those outcomes between patients fed trophic feeds versus full feeds. We aren't the only ones that have had this concept. This is Yassine Arabi's PERMIT study, which was published a couple of years ago. They did a similar thing, although they wanted to just vary caloric intake and keep protein intake the same. So you can see they randomized patients, there's about 700, 800 patients in this study. They randomized them to a moderate amount of enteral nutrition, 40 to 50% of their goal requirements, or trying to get to goal as fast and as feasible as possible, which gives you about 80% of your goal calories, but maintaining the same level of protein intake, again, about 80% of your goal protein intake. These are their outcomes, and you can see just scanning their outcomes that they don't see any difference between any of their outcomes, save the bottom, which is actual dialysis and new dialysis, and that was actually lower in the permissive underfeeding group, so the group that was targeting 40 to 50% of their goal calories. I think this is probably not a real signal. I think it's probably a statistical anomaly of running a bunch of tests, but it certainly, even if it isn't an anomaly, it doesn't favor the standard full feeding group. It favors the permissive underfeeding group. All of the other outcomes are similar between groups, including death at whatever time point you want, duration of mechanical ventilation, or days alive and off of mechanical ventilation. Same with ICU length of stay and ICU days alive and out of the ICU. So taking all of these studies and putting them together, Choi and Park in 2015 did a meta-analysis of trophic versus full feeding. They had about 1,500 participants. They looked primarily at mortality and couldn't see any difference in mortality between trophic and full feeding. They did a subgroup analysis, which is interesting, in that if you were in the trophic group and got greater than a third of your goal calories, then it looked like maybe that was protective compared to both less than a third of your goal calories and if you got full goal calories, with an odds ratio of 0.61, meaning a 39% reduction in mortality. They looked at hospital and ICU length of stay as secondary outcomes, couldn't see any difference, and they looked at GI intolerances. And although they were numerically higher in the full feeding group, it didn't reach statistical significance compared to the trophic. So again, some evidence that full feeding is not necessarily beneficial for our patients, and that we get similar effect from lower level, i.e. trophic feeding. And then the last study I'll show you in this realm was just published last September and October in the New England Journal by the Australian trials group called ANZIX. And they looked at, this trial is called Target, they looked at energy dense versus routine enteral nutrition. And they did this in a blinded manner. So they randomized patients to 1.5 calories per cc of enteral nutrition formula, or 1 calorie per cc per milliliter of enteral nutrition formula. And they ran that formula at 1 cc per hour for every kilo of weight that the patient was. And they did it in a blinded fashion. They didn't know which formula the patient was getting for their ICU stay. And you can see this resulted in the routine nutrition group getting about 1,400 kilocalories per day, and the energy dense gets between 1,800 and 1,900 kilocalories per day, which turns out to be about 60% versus the high 90% of the goal calories for these patients. And again, they looked at survival, no difference in survival, even up through day 90. And then they looked at a number of subgroups in the panel on the right, and there's really no difference in any of those subgroups between reaching goal calories or getting about 2/3 of your goal calories. So another kind of indication that maybe trying to feed everybody with goal calories isn't best for our patients. And this is actually data that says, well, what is the right amount then? This is a retrospective study, 1,200 patients in the ICU over 13 years. All of them had indirect calorimetry, so they knew what their resting energy expenditure was. And they showed that the sweet spot on this, the spot that has the highest survival, is actually if you get about 2/3 of your goal calories or 2/3 of your energy expenditure. If you get more than your goal calories or more than your energy expenditure, you do slightly worse. And if you get in the trophic group or 30%, you do even worse than the kind of full fed group. So all of these data suggest that there might be a sweet spot someplace in the 40 to 60, 40 to 70% range of goal calories. What about the data that suggests that protein may be even more important than non-protein calories? So this is some emerging data, and I'll show you 3 different kind of data sets that have found that this might be the case. So this is again a retrospective study, almost 3,000 mechanically ventilated patients from across the world in 200 ICUs in the nutrition database that Darren Highland has in Canada, and they looked at protein intake for the first 4 days with how likely the patient was to die during their hospitalization. And you can see these are by high risk Nutrix score, which is the dark black line, and lower risk, which is the kind of gray line. But you can see for both of them, there's a negative slope, meaning the more protein you get, the lower your probability of mortality. And that slope is actually statistically significantly negative in the high risk group, meaning that it appears there's a real association between the amount of protein intake and mortality in those patients. There's some other groups that have shown similarly. This is Peter Weiss's group. They looked at 843 ICU patients. They looked at energy separate from protein. So this left panel is actually energy. And you can see from this that the group with the lowest mortality is about a 10 to 20% energy deficit. If you have more than a 20% deficit during your ICU stay, you have a slightly higher mortality. But it turns out if you have no deficit or even a slight 0 to 10% deficit, you still have higher mortality than if you have this 10 to 20% deficit. Again, suggesting that maybe someplace in the 2/3, 3/4 of your goal energy is the right amount. But protein, you can look at the protein over here, and essentially as you increase the protein amount, mortality goes down, not a lot here for the non-septic patients, but it still goes down. And in the most sick, the septic patients, it really goes down as you increase your protein, and not a U-shaped curve like it is for energy. This is the same sort of curves, different group, Pierre Singer's group, but same sort of curves, showing this is delivered calories as a percent of your resting energy expenditure. Again, that's 60 to 70%. Odds ratio for mortality is the lowest, so highest survival here, as opposed to protein, which pretty much is a negative slope with better outcomes as you get more and more protein, suggesting protein is more important. All right, so we've talked a little bit about the amount of composition of enteral nutrition. Now let's move on to the actual serum glucose and how they might affect patient outcomes. So we know a number of things about glucose in critically ill patients. Hyperglycemia is very common in patients that are in the ICU, and that actually being critically ill worsens insulin sensitivity and makes it so that your body tissues are less sensitive to insulin or more insulin resistance, which is part of the contributing force to the hyperglycemia. Hyperglycemia is associated with the severity of critical illness, so sicker patients in general tend to have higher blood sugar levels, and they have worsening insulin resistance. And there are some data that suggest that hyperglycemia may not just be associated with outcomes, but may actually be the cause of worse outcomes. Similarly, and I'll show you these data, there are data that hypoglycemia is also associated and potentially the cause of worse outcomes. And there are some emerging data that say that it may not even just be the actual blood sugar level, but it may be how much variability there is in that level. So patients who have wide variability in their blood sugars during their ICU stay may actually be the patients that do the worst. So where do these data actually come from? So the very first study, big study in this area was done in 2001, published in 2001 by Greet Vandenberg and her colleagues in Belgium. They took 1,548 patients from their own hospital's surgical ICU, randomized them to intensive insulin therapy, defined as giving insulin to control your blood sugars in the range of 80 to 110, versus conventional treatment, which was allowing the blood sugars to be 180 to 200, still using insulin if needed above 200, but letting them be 180 to 200. They did a continuous insulin infusion, and their primary endpoint was death during their ICU stay. You can see from this that the patients in the intensive treatment got more insulin, longer amounts of insulin, and had lower blood sugars, 103 versus 153 as a blood sugar, morning blood sugar measurement. So they had better control in the intensive treatment group than the conventional treatment group, and used more insulin to get that better control. Now you may say, well, if they were targeting 180 to 200, why are the blood sugars in the conventional treatment group 153? And that's because if they were below 180, so between 80 and 180, they didn't do anything. They didn't give insulin, but they accepted that as an acceptable blood sugar. So not all those patients got insulin. Here's the actual mortality data, and you can see the intensive treatment group has higher survival, lower mortality in both the ICU and the hospital. So these were really great data that made a lot of us change practice and start doing intensive insulin treatment. But Greet and Dr. Vandenberg and her colleagues said, well, that was a surgical ICU. What's it like in the medical ICU? So this is the actual next study, which was published in 2006 in the medical ICU. And you can see on the left-hand side, which is all patients, intensive treatment doesn't really have the effect, the benefit in the medical ICU that it had in the surgical ICU for both up to a year, even a year and a half, or the first 30 days. If you look at just the patients that were in the medical ICU for at least 3 days, though, you start to see this separation again, and there may be some difference in the amount of exposure to insulin that these patients were getting. So not as provocative and exciting, but still maybe a signal there for the patients that were in the medical ICU for at least 3 days. And here are some other outcomes for those patients. They come off the ventilator faster, they get out of the ICU faster, and they're discharged from the hospital faster. So all of those were kind of exciting and made lots of us start doing kind of this tight insulin control. But then there was a study called the NICE Sugar Study, which is a huge study. It's a randomized trial of 6,000 patients from 42 medical surgical ICUs. You only could get in if your expected length of stay in the ICU was at least 3 days. They randomized you to a glucose target, again, of 81 to 108 or less than 180. Those are the two groups, kind of tight control versus kind of moderate control. And again, their endpoint was death by any cause at day 90. Here you can see that they actually did get a difference in their groups. The conventional glucose control has a sugar of about 150. Their tight glucose control has sugars that are about 110 to 120, so they didn't quite get to 108, but they are better than the 150. And they actually have a narrower dispersion, less variability in that intensive control group. They did find a difference in mortality between the groups, but it went the opposite way. So the less tight control, the conventional glucose control, or less than 180, actually had lower mortality at both day 28 and day 90. And the tight glucose control actually had a higher mortality and worse outcomes. And this really made a lot of people relook at tight glucose control and what was happening with blood sugars in the ICU, including the group that did NICE Sugar. And specifically, they started looking at hypoglycemia and said, what is hypoglycemia's contribution to these outcomes? And you can see from Vandenberg's first study in the surgical patients, they have a relatively low rate of hypoglycemia in their intensive treatment group and a really low rate in their control group. In the medical patients, they have a much higher rate of hypoglycemia in the treatment group. And in nice sugar, they had an intermediate rate of hypoglycemia in their tight glucose control group. But they did have, and they report, a lot of moderate hypoglycemia. So sugars 41 to 70. So even though they didn't meet the severe hypoglycemia, almost 3/4 of the patients had sugars below 70 at some point. You say, well, is hypoglycemia really that big of a deal? So the nice sugar investigators looked at hypoglycemia and the risk of death. And just the intensive glucose control group, if you had moderate hypoglycemia, your risk of death was increased 24-fold. If you had severe hypoglycemia, it was increased 16-fold, both highly significant and severe risks. And they said, if you compare that to the patients in the groups that didn't have hypoglycemia, you can see, again, an increased risk of death or hazard of death in the groups, in the intensive control group that had moderate hypoglycemia or severe hypoglycemia. Interestingly, it's also true in the conventional control. So it wasn't just the tight control group, but if you had hypoglycemia in the conventional control, you also had higher risks of death. And the duration of hypoglycemia matters too. So if you just had it on one day, you have an increased risk of death. But if you had it on more than one day, then that risk is even higher for death, for both moderate and severe hypoglycemia. So the message coming from this is that if you had any hypoglycemia, that was bad. If you had a more severe level of hypoglycemia, that was bad. And if it was a longer duration, that was worse than a shorter duration. So we in the medical profession have a kind of first do no harm thought process and view, and this scared many people and made many people much less aggressive with their glucose control because of the fact that it appears that when we are that aggressive, we may actually cause hypoglycemia and maybe even to the detriment of our patients. So the concept then came around is, what if we could maintain better blood glucose control while reducing the risk for hypoglycemia, and do it instead of with insulin, but do it through a nutritional formula? So there's a couple of studies that are newly out that kind of have looked at this. This was actually a study by Macejo and colleagues in 2015 where they looked at two different diabetic formulas in a blinded randomized multi-center study. And you can see that this is actually not a diabetic formula, group B. Group A and C are both diabetic formulas. And the diabetic formulas actually decreased the amount of insulin, actually slightly improved the plasma glucose levels, whether you looked at the plasma or the capillary levels, but didn't really have a whole lot of effect on other outcomes. Did actually lower hypoglycemia, so that's good, but didn't have effect on other clinical outcomes. Here's actually another one looking at a low carbohydrate formula, saying maybe if we just give low carbs that we can do the same thing, and really didn't find any difference even in blood sugars levels except for Accu-Check glucoses, which were slightly lower in the low carbohydrate formula, but it wasn't confirmed by blood gas glucose or by laboratory glucose. And again, no difference in clinical outcomes. They did, and I think it's probably spurious, find a little less insulin administration, but only on day 2 in these patients, and otherwise similar amounts of insulin administration. There's the glucose levels. And then most recently, and this is just in an abstract, and I took it off the Diabetes Association website because that's the only place that it's available. Cumbier and colleagues actually did a crossover trial and showed that if you use a different type of sugar, i.e. fructose instead of glucose in your enteral formula, that you actually have better blood sugar control. They didn't look at clinical outcomes because it's a crossover trial, but essentially a fructose decreased the glucoses by about 15 in these critically ill patients in this study. So we tried to do the same thing, but we tried to do it a little bit on steroids. So we said, what if we could do all of the concepts that I've talked about in this talk? What if we could do permissive underfeeding with less carbohydrate, adequate levels of protein, and specifically make it whey protein with the intention of maintaining better blood glucose control, reducing the risk for hypoglycemia, and do it with a nutritional formula and not have to use insulin. And that was the concept behind the DIVINE study. So the DIVINE study, which is now published in print as an EPUB in JPEN out at the end of last year, stands for the Dietary Management of Glucose Variability in the ICU. And when I talk about this study, I just want to make a comment that if you're searching for an acronym and you have to use the first two letters of the first term in your study name, then skip a couple terms, then take two letters that aren't consecutive from the fifth or sixth term, an N in and an E in the to come up with your acronym, then you've dug pretty hard to come up with DIVINE. So we really overthought this to come up with DIVINE as our acronym, but we made it work. Here's what we were trying to do. We were trying to determine whether blood glucose control could be improved by using an enteral nutrition formula that was low in carbohydrates, low in medium chain triglycerides, had very high levels of hydrolyzed whey protein, so that we could ensure optimal protein delivery even though we were doing permissive underfeeding from a calorie standpoint. This was an open label, multi-center randomized trial at 7 academic medical centers in North America. The goal was to put in 280 patients, for 160 of those to complete 5 days of enteral nutrition therapy. And we thought that that would be about the ratio that we would need. We enrolled for a couple years, from August of 2014 through July of 2016. Patients we enrolled were mechanically ventilated in the ICU, had to be at least obese and up to overweight, so a BMI of 26 to 45, getting enteral nutrition and thought to be getting it for at least 5 days. We excluded patients with hepatic failure, if you were a trauma admission, if you had had major surgery in the past 30 days, or you were planning on having surgery in the next 7 days, pregnant females, type 1 diabetics, burns patients, and then obviously anybody that we were unable to feed enterally, we excluded. The intervention that I'll show you on the next slide was a high protein formula as the control group, with the experimental group being a very high protein formula with low carbohydrates. Actually, it's on the lower part of this slide, sorry. So here you can see the control group was a caloric density of 1, same as the experimental group, but the protein was about what we normally feed, 25% of the energy. Carbohydrates higher, almost 50% of the energy, and fats the remaining 30%. Compared to the experimental group, which had even a higher level of protein, 92 grams per liter instead of 64, so about 50% more, and about 50% less carbohydrates, so 76 grams per liter instead of 112, with similar amounts of fat. And the goal in both groups was to deliver 1.5 grams per kilo per day of protein. And I'll show you how we do on that in the next couple slides. The outcome was the rate of glycemic events outside the interval of 110 to 150 milligrams per deciliter during the first 7 ICU days. And I'll show you the dispersion in a couple slides. There were a number of secondary endpoints, including what the glucose levels were, markers of nutritional status, some biochemical endpoints that I won't show you today, and then some clinical outcomes that I'll show you at the very, very end. So here's how the trial went. So enrollment, there were 106 patients assigned consent, 105 were actually randomized, 53 of those allocated to the control group, and 52 to the experimental group with a very high protein, low carbohydrate. Of those, 50 and 48 received the intervention and got follow-up in the trial. During the 7-day follow-up, 3 were lost to follow-up in the control group, and 5 were lost to follow-up in the experimental group. And then you can see a number of them discontinued the intervention during those 7 days, either because they were palliative or because they were discharged out of the ICU, which is obviously a positive result. Of those 105 that were randomized, 102 had glucose measurements available and are included in the analyses that I'm showing you going forward. So here's the actual baseline characteristics of the patients. You can see that the biggest admission diagnosis was acute respiratory failure. Sepsis is second. Pneumonia is actually the third. About 15% of the patients did have a neurologic cause for admission to the ICU. BMI was about 33 in both groups. Apache 2 was 25. These patients were sick in both groups. And you can see that they were not type 1 diabetics, so their hemoglobin A1C was okay. Here's what we actually did. The experimental group received significantly fewer calories. That was purposeful. We hoped to do that. Both groups received similar amounts of protein. That was also purposeful. We were hoping to make this isonitrogenous. And the experimental group received significantly less carbohydrate. That's how they got fewer calories. So if you look at the actual numbers, the control group got about 18 kilocalories per kilo per day. Experimental got about 2/3 of that, 12.5. Both got 1.1 to 1.2 grams per kilo per day of protein. We were targeting 1.5, so not quite what we were targeting, but similar between the groups. Carbohydrates, the experimental group got about half, about 1 gram per kilo per day compared to 2 for the control, and fat was similar between the two groups. Here's the actual protein and energy intake between the two groups. You can see it's really, really similar protein intake across the 6 days, 7 days on protocol. Day 6 because we call the first day, day 0. Between the protein, the calories, the energy intake was actually different, and it was about 2/3 for those days for the experimental group on protocol. About 12 to 18 comparison. So here's the actual dispersion of the glucoses. There was no difference actually in our primary outcome of events outside of this range, outside of the interval of 110 to 150 milliequivalents per deciliter. But there was a significant increase in the number of events in the normal range, i.e. 70 to 110 in the experimental group, and a significant reduction in the values greater than 150 in the experimental group. So no difference in the actual groups that were 110 to 150, but more 70 to 110 and fewer less than 150. And in fact, if you look at the dispersion, the mean glucose was lower in the experimental group. The variability was actually similar between the two groups. There was no difference in the rates of hypoglycemia, or blood sugars less than 70. And there was a slightly smaller dispersion in the experimental group, but very, very similar. There was less insulin administration in the experimental group. So despite having lower blood sugars and less variability, they did that with receiving less insulin, and no difference in the amount of rescue dextrose that was needed for hypoglycemia, which is consistent with the finding of no difference in the number of hypoglycemic events. What about other results? The tolerance and adverse events. There was some abdominal distension in the experimental group. It was formula related in one experimental patient, and that formula was withdrawn. But overall, adverse events were not different between the groups. And there was a lower percent of mortality, so fewer deaths in the experimental groups, although it didn't reach statistical significance. It's still only 1/3 of the percent, 4 versus 12% mortality in the experimental group. So some provocative results. The trial was actually stopped early because the DSMB got worried about the blood sugars between 70 and 110 and that they were higher in the intervention group, and that's why they stopped it. Even though when we looked at it, we don't think that was a harm to the patients. So if you followed this, then you say, well, the glucose was better in the experimental group, but why was the glucose control better in that group? And I think it's probably a combination of a number of factors. There are some data that show that a high protein load improves insulin sensitivity. So giving more protein and a higher load in the experimental group, or at least a higher concentration in the experimental group, may improve sensitivity. It's also a whey protein that may by itself improve insulin sensitivity over non-whey proteins. Lower carbohydrate delivery has been shown repeatedly to result in better glucose control, including in addition, overall lower calorie delivery, so hypocaloric feeds results in better glucose control. And I'll show you from our Eden trial that we found that, and here it is for the Eden trial. You found that if you were given trophic feeds, your plasma glucose was actually lower. These are 8 a.m. levels, but lower in the trophic feeds group. And just like in the Divine study, in the Eden study, the trophic group got less insulin and still had lower blood sugars, even getting less insulin. So a quick summary of Divine. A very high hydrolyzed whey protein and low carbohydrate formula facilitates blood glucose control in critically overweight and obese patients. And although the formula didn't actually reduce the percent or the number of blood glucose events that were outside of the interval of 6.1 to 8.3, it did lower dispersion of the blood glucose, resulted in a lower incidence of blood sugars greater than 150 and a higher incidence of normal blood sugars between 70 and 110 milliequivalents per deciliter. And it did that while decreasing insulin use without increasing adverse events. So overall conclusions of this discussion and this talk: nutritional support for critically ill patients needs to be individualized. And this concept of let's just feed everybody full feeds from the beginning with what I call tube feed du jour, which is the classic composition of what normal people kind of eat, hasn't been shown to be beneficial for our patients. Current data suggests that moderate permissive underfeeding while administering higher levels of protein may actually improve the outcomes of critically ill patients, someplace in that kind of 50 to 70% of goal range for the first up to maybe a week of ICU stay. Avoiding hyper and hypoglycemia likely improves outcomes, and it may be best to do this through specific nutritional formulas. Those could be with fructose instead of glucose, lower carbohydrate formulas, or as we did, a combination of lower carbohydrate, higher protein, more whey protein, to try and hit on a number of different factors that could control blood sugars. And we think that we probably need to explore this further to see if these formulas actually can improve real clinical outcomes that we care about, like mortality, time on the ventilator, ICU length of stay, etc. So that finishes what I was planning to talk about in this webinar, and I'll try and turn it back over to Yvette for questions that people may have.
Wonderful. Thank you so much, Dr. Rice. A very informative presentation. Our first question, Dr. Rice, in the study formula, when you were talking about the DIVINE trial, you mentioned that it contained hydrolyzed whey. I know there's MCT, and both of these are insulinotropic, in addition to the carbohydrate content of that study formula. Do you think that this positively supported the statistically significant outcomes noted? For example, like the lower mean glucose and the decrease in the amount of time that insulin had to be administered. Could you elaborate?
Right, yeah. So I touched on it kind of at the end. The question when we got the results was, okay, it looks like blood sugars are probably better with this experimental formula. Why do we think that is? And I think you've hit on a number of things that probably all contribute. So whey protein is insulin-trophic and improves insulin resistance, and as do some medium chain triglycerides. We had lower carbohydrates, which also probably contributed, and it's probably a combination of those that contributed to the effects that we saw in blood sugar. Trying to figure out the optimal way to manage these patients, I think we still have a fair amount of work to do, but I think the overall concept of trying to use a specific nutritional formula to control blood sugars, decrease insulin use, and hopefully improve the outcomes of our patients is provocative and certainly something that appears to be feasible and should be explored further.
Okay, great. Thank you. Another question that I received is a little bit along the lines of this first question. There's a question about this insulinotropic effect from the whey. Can you share a little bit more on how it's whey protein, or what the effect is from whey protein to help with the insulin response?
Wow, that's a tough question. I don't know that I understand all of the biochemistry, but at least in lots of kind of ex vivo, so out of the body models, and even now some in the body, whey protein, it just has biochemical effects that allows the cells to use insulin in a more sensitive manner. So essentially they're more sensitive to insulin, and therefore they take up more glucose at the same amount of insulin. I certainly don't understand it, and I'm not sure even the kind of high level biochemists understand it. But it does go to kind of say that the composition of the components of the formula, so the type of carbohydrate, whether it's fructose or glucose, the type of protein, whey versus non-whey, probably does have metabolic effects within the body. And I think for most of us, if we've been in the nutrition world for a little while at least, that's probably not surprising. We know different foods and different compositions have different effects. So sorry, I can't explain it in depth any more than that. I'm not a diehard biochemist, but it does appear that the whey protein kind of improves the actions of insulin. So insulin works better when the body's using whey protein as opposed to non-whey protein.
Yeah. I can add, I know there is a very nice review article that's available. The lead author is Rachel Adams, and I believe that particular paper does go into a lot more detail, including the biochemistry, looking at, oh goodness, like a glucagon-like peptide, so the GLP-1.
GLP.
If anybody is interested or wants to learn more about the, we'll say, insulinotropic effects of whey, if you Google Rachel Adams, I'm sure that paper will pop up. I have another question. I know this question actually comes up from time to time as well. So as you shared your data, Dr. Rice, and the question about full feeds versus trophic feeds in the critically ill, and certainly I know we can't treat the patients in the ICU necessarily as a one-size-fits-all. Can you share about what you use as your parameters, or what types of patients, when you share the data about trophic feeding having better results when it comes to decrease in mortality? Because as you know, there are volume-based feeding protocols that are being utilized in ICUs. And so what factors do you take into consideration with your patients when to consider, whether it's appropriate to be more aggressive or not to be as aggressive with your patients?
Yeah, I don't know that we know the factors that should prompt us to be really, really aggressive in trying to feed our patients. And so what I do is that I have my nurses in the ICU start some enteral feeds. I like to say within that first day, it's usually based off of our metrics about at 24 hours after admission. And I tell them, I say, just start 10 to 20 cc's an hour. It turns out that makes the nurses a lot less anxious. They'll start something, and in general, they won't have a lot of feeding intolerance problems with that rate. And they'll run it, and then a couple days down the road, usually day 3, someplace in that day 3 range, the chaos of the new ICU admission has kind of settled down. The patient's a little bit more stable. And most of the time, the nurses will actually come to me and say, hey, I know we're running trophic feeds. Do you care if I advance them to full feeds at this point? And I think the data are such that the outcomes were similar between trophic and full feeds. So I don't think that's harmful to the patients. And I say, sure, yeah, advance them to full feeds. And usually the nurses will do that. And then it's all based off of patient tolerance. If the patient tolerates that, great. If they don't, then I often will say, okay, let's just keep doing 10 to 20 cc's an hour for another day or two, and then we'll try again, a couple days down the road. So I do tend to be a little bit more aggressive with my dialysis patients because a lot of what I think they need is more protein than the trophic feeds get, and so I'll move those up a little faster, especially if they're on CRRT, for example. But otherwise, it's a pretty standard. I'm not a deep thinker, so it's a fairly simple approach that I take.
And I mean, what I can share too from, in the ICU patients too, even with a volume-based feeding protocol, that is something that the goal may be to get to your goal or full feeds, but that realistically also takes some time to get there. It's not something that necessarily is going to start day one and reach that goal amount within that first day either. It's something that you advance as tolerated. And I agree with you. I think that patient tolerates, how they tolerate is going to dictate the next plan of care, or how you want to proceed with the delivery of that formula.
Right.
And I
yeah.
From your from the studies and what you were presenting today, clearly, is really looking closely at the type of formula that is used in addition to how it's being delivered.
Yeah.
Okay. Let's see. I have another question that just came in. Do you have a preference, or do the dietitians that you work with, do they have a preference for the caloric feeding density? So again, you've mentioned how we don't want to overfeed and focus on the protein. So do you tend to use a more calorically dense formula, or do you usually see the use of a 1 cal per ml formula used in your ICU?
Yeah, it's another good question. For us, it's all logistics based, and what I mean by that is that if we are trying to fluid restrict the patient or minimize fluid, then we'll use a more caloric dense formula. But if we're not, then we will use a traditional 1 to 1. Sometimes up to 1.5, but not higher than 1.5 kilocalories per cc. So our heart failure patients, are kind of renal failure that haven't started dialysis yet patients, where we're trying to really watch the fluids, will get the higher caloric density. But in general, the rest of the patients get kind of a standard caloric density formula.
Here's another interesting question. What other clinical data or evidence that you've become aware of with the DIVINE study would you like to see explored in the future with future studies?
Yeah, I mean, I think blood sugar control is an interesting endpoint, and insulin administration, makes it even a little bit more interesting. And I think in general we care some about that because it prompts us to do stuff. So if your blood sugar is really out of control, the nurse has to give you insulin and we have to monitor it and that sort of stuff. So I think those are provocative, but I think the endpoints and the outcomes that our patients care about and we as clinicians should therefore care about are more higher end clinical endpoints, like how long you're in the ICU, how long you're on the ventilator, even mortality, and do these things affect mortality? And to do those, to look at those, we'll need bigger studies with more patients. But I think ultimately those are the endpoints we need to study and figure out, what are the effects on those clinical endpoints of the different types of methods and compositions of formulas that we use to feed patients.
I have another question here. Just in general, the question is, could it be that underfeeding of carbohydrate while providing adequate calories is more important than underfeeding total calories when trying to attain blood glucose control?
Right. Yeah, totally. If you give less sugar, then it's not a surprise that the blood sugars may not go as high. If you don't give your critically ill patients a Snickers bar every single day, their blood sugars may not be as high. And so I think percent of an amount of carbohydrates is a component that matters, and that can affect blood sugars. I think others have shown, with the diabetic formulas, that has some effect, not necessarily a huge effect, but some effect on our patients. I think it's an easy thing to do, and I think we should prioritize, thinking about giving less carbohydrates. In the past, many of you may know that there were lots of talks about lipid and carbohydrate composition, especially in patients with respiratory failure, and your respiratory quotient and how much CO2 you'd produce from those calories. And in general, we in the critical care world have done better at studying those recently and have been unable to see that there's a huge difference between CO2 production between a high lipid formula and a high carbohydrate formula. And from that, I wouldn't use that concern to drive what the composition of your formula is.
Let's see, I have another question that just came in. So when you're looking for a formula for the particular critically ill patients that you've been talking about and that you see in your ICU, what is the overall composition that you're looking for, like percent of carbohydrate, percent of protein, and percent of fat?
Yeah. I'll be honest, before this trial, we used something that was about 50% carbohydrates, about 20% fat, 20% protein, 30% fat. And we've changed some with this trial, so we use a lot more of the kind of 30 to 35% protein, still 30 to 35% fat, and then 25 to 35% carbohydrate type formulas. So we're giving fewer carbohydrates, less percentage of carbohydrates, kind of after this study. I'm at an institution, many of you probably are also, that is fairly cost conscious. So we haven't been willing to do this if it's going to cost us 10 times as much to do the feeds. But in general, it's essentially very similar cost. And for a similar cost, we think it's probably as easy as changing the prescription and the formula to just a different one. We think it's pretty easy to do, and so we've tried to implement that in our ICU.
I know we just have a couple minutes left. There was a question that came in about the, you mentioned how you want to give more protein, especially for your dialysis patients or those that are on CRRT.
Yeah.
What do you typically in your ICU provide, or what is your range of protein for those patients?
Yeah, so we're trying to do 2 grams per kilo per day. That's a hard level to get to. And we use protein packets as supplementation. We don't use IV amino acids. We use enteral protein packets. I think the actual answer to the question that you posed is unknown, though. And I think it's not only for dialysis patients. I think it's true for all of our critically ill patients. There are guidelines that recommend, 1.2 to 2 grams per kilo per day for critically ill patients. But the randomized data, I showed you some of the observational data that more protein is better, but the randomized data are almost non-existent. And there are currently at least 2, maybe 3 studies that I know of that are ongoing, studying that and trying to figure out, what the right target for grams per kilo per day of protein for our critically ill patients is. And it may vary depending on, as you've pointed out, what the patient's condition is. So our dialysis patients may need more, may need less, or maybe it may need the same amount. But I think we'll get better data on those from some of the ongoing trials, and better data even on some of the subpopulations.
Wonderful. Well, I do want to be respectful of everyone's time, and I do see that we are towards the end of the hour today. So I just want to thank you again, Dr. Rice, for an excellent presentation. I also want to thank our audience. We do appreciate your participation today. And on behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice, and enjoy the rest of your day. Thanks so much.